just unmute folks as they join. So welcome to those of you who are joining us for the first time, and for those who are returning, welcome back to our We're All in This Together weekly best practices calls. This has been a really great collaborative opportunity for us over time to engage with our partners at health systems around the country as we look to share best practices around COVID-19, both in the original surge and ongoing, and recovery strategies and management strategies now that we seem to be kind of riding another wave here. So these have historically been a weekly teleconference designed to promote open dialogue among our partners and incorporate collaboration outside of these weekly sessions in our healthcare education website dedicated to giving you an opportunity to incorporate your ideas. So share your ideas with your colleagues at that site. We will download the content from each of these sessions and post little mini blogs about some of the innovations that our partners have shared with us on these calls. And then, of course, you can listen to the recordings at your leisure or share them with your colleagues who might not have been able to attend the call. A real few number of housekeeping items. The audio settings are such that we have everybody enter on mute. So as soon as I stop talking, I'll go ahead and unmute everyone. And if you have any concerns about background noise, please remute yourself. And that way you'll be able to sort of control when you jump in and out of the conversation. The recording will be, a session will be recorded, as I mentioned, and documented. And then for at the end of the survey, at the end of the seminar, you'll get a survey from us where you'll be asked about, you know, what value you got out of it. If you have any suggestions for topics that you'd like to hear at a future best practices call or at one of our upcoming educational summits, that's a great place to share your ideas with us. And then as you introduce yourself, please take a minute to let us know who you are, which health system you're in, and sort of what your current state of COVID is, because we've experienced in the early days, you know, folks waiting for a surge that didn't come, or others that were in the middle of it and then it waned, and now a number of places in the country are starting to tick up. So it'll be interesting to see where everybody is in that process. So having said all that, I wanted to just take a moment to welcome our moderators for today's call. We're very excited to have Candace McGovern and Michelle Bombauer joining us from University Hospitals in Cleveland. Candace is the Director of Clinical Applications there and has been with UH since 1996, where she was has an ED background as a nurse manager. She's worked in healthcare IT since 2008 and currently oversees primarily inpatient EMR, pharmacy, and surgery applications. Michelle's the manager of clinical applications, is also a nurse in her background and has been with UH since 2008. She has a background in critical care and nursing management and 15 years of healthcare IT experience. She serves on the Northern Ohio HIMSS board and manages perioperative oncology and device integration. So they're going to share their story, their COVID story from University Hospitals and some of the innovations they developed to help them manage through the crisis. So Candace, Michelle, welcome. I'll hand it over to you.
Thank you, Stephanie. It's a pleasure to spend some time today talking. I was unfortunate in that I didn't get to attend a lot of these prior to, and so, you know, I hope at least when I did attend, it was very interactive. So I hope we can continue to have that be the case today. Michelle's going to focus a bit later on some of the updates that were made around ambulatory oncology, which she oversees, as well as surgery. And I'm quite certain that you all have an experience similar to ours in that, you know, getting surgeries back, which is a main driver financially for our health system, has been a real focus. So, you know, that's one of her focus areas in the last several months. There are a couple of other supporting cast members on the phone. I saw Wendy Bonsteel. She works with UH on the testing team, so glad to have her here and welcome her input on anything you know, UH related that I don't cover. as well as Zachary Brott. He's the manager of clinical applications on my team as well, and oversees really our core inpatient EMR clinical documentation and orders and results and so forth. So, so we can probably go to the next slide, Stephanie. So I wanted to just give an overview of our health system based out of Cleveland, Ohio, and really kind of covers regionally the northeast corner of Ohio, totaling 15 counties. We have 11 community medical centers. So they range from critical access, small critical access, to very busy kind of regional centers for heart and stroke care. So some of our community medical centers are very busy, kind of hot spots in Northeast Ohio. And we have one large main academic medical center that has a women's health hospital, Sideman Cancer Center, Rainbow Babies and Children's. So we range the gamut. So I wanted to put the numbers here. This data is from 2018, so not the most recent. We had prepared, like many of you probably on the phone, we had prepared to go to HIMSS in early March, and this is one of the slides we had available to us in mid to late February, and so I'm sure there's one that's 2019 with the latest and greatest, but I ended up repurposing this one. So obviously lots of outpatient procedures. That's and key to our story around COVID. Physician visits as well. Of the physician visits, a very, very small number were virtual prior to March of this year. And in the month of April, I think, we went up exponentially, 900% or something. The virtual visits had increased in 1 month. So emergency department visits, very busy. ED down at the main medical center, as well as some of those regional hotspots in the health system, accounting for almost 500,000 emergency department visits a year. We had 6 freestanding emergency departments. We'll talk a little bit about that. And then urgent care visits, 144,000. So over 1.2 million unique patients seen in 2018, and over 3,000 registered beds. You can go to the next slide. So one of the things I think was key, back up, I'm sorry, Stephanie. Oh, no, you were right. You kind of skipped over. Go ahead. You can proceed there. All right, so I did slide, I hid this slide, but I think it's pertinent to our story, because at UH, we do not have a fully integrated EMR and IT system. We have Allscripts products on the clinical side, and we have Cerner Sorian for financials. So I think that's part of our story, right? And so as we go through this, some of the efforts, and I'm curious to know those health systems that have Epic or Cerner fully integrated, if our experience would have been different. So our inpatient EMR is separate from our ambulatory EMR. So Michelle and I represent the inpatient EMR and ambulatory oncology, but there are other teams at UH and IT that oversee the financial system, ADT, and so forth. And there's obviously always a need for integration. So I think that's key to where we are, and in our journey through this COVID is that it was complicated. Everything was complicated. So, okay, you can go to the next slide. I'm not gonna cover that detail. So one of the things we did to kind of keep ourselves in line was this creation of a request tracker. So how many on the phone use ServiceNow for IT incidents, problem, record? Is that common?
Yes.
Okay. So we utilize that for a tracking mechanism for all things related to the pandemic. So this pandemic request tracker was created in, I would say, mid-March. So in addition to having 28,000 employees at UH, of that, 660 of them are in IT. And we had, when our incident command structure was set up, we really only have a couple of those individuals as part of the incident command. So on a direct basis, having a seat, so to speak, in the hospital incident command. Robert Erdley, our Chief Information Officer, and Jen Carpenter were really the primary contacts for IT in the incident command. So one of the calls that I was on a few weeks ago, we talked through that a little bit, was that IT was behind the scenes, but even the leadership was behind the scenes. So we have 4 vice presidents in IT, and then we have in total about 14 directors. So each one of us, kind of played a role, but mostly behind the scenes. And Jennifer Carpenter, who's the VP of Clinical Systems, and Robert Erdley utilized this tool to be able to give regular updates on the incident command calls. And those calls are still taking place twice per day. So our incident command is still, up and running, and has been, for several months now. So, I guess the question is to the whole group, is that what's taking place at other health systems and hospitals as well? You still have that formal incident command. All right. I think this tool was especially handy, and I wanted to give an overview of what did it mean. So if you go to the next slide, Stephanie, we were able to generate this report, and for the most part, the majority of the requests were related to patient access, portals, and patient engagement. So that accounted for close to 40% of all of the requests since early March. And although I'm not directly involved in patient access, portals, and patient engagement, I kind of wanted to give an overview of those things and the response efforts on that side. So we had, started with the screening of patients when they were scheduling appointments, right? So the earliest phases, screening of those patients, ensuring that there was documentation for the patient access representatives to document any concerns around travel or interaction with somebody that had COVID. And then, quickly moved on to cancellations of surgeries and appointments that were non-essential. And the flexing to the virtual options for those patients. They have a number of efforts towards tracking those individuals and ensuring that we kind of kept them involved with either home health or their care providers directly by phone. And then we moved on to other things like, for example, just volume, right? Being able to shift from a volume standpoint. So I mentioned we had those freestanding emergency departments, and the volumes were so low that at some point during this time period, they ended up closing those 6 freestanding emergency departments and reopening them as urgent cares. And so that was key because, as I said before, the EDs, they're part of the inpatient EMR. We ended up switching them over to our outpatient EMR during that time. So imagine the change management at that point, to have EDs using one EMR and and then reopening the next day as an urgent care using a different EMR. So it was pretty mind-blowing, I think.
Hi, this is
but
Goldlinger.
we
Quick question. Yeah. Was that a permanent change, switching the freestanding EMRs to an ambulatory site, or was that temporary during the COVID, just temporary for the COVID crisis?
Well, I think that's a good question. And in my mind, I'm not sure, right? So I haven't been involved in conversations that, I think it all depends on volume and patient acuity, right? So I think they will likely remain urgent cares for a lengthy period of time, right? So it still remains to be seen. Our ED volumes are still quite low, and these EDs, like I said, there are 6 of them. Some of them we were seeing 2 patients in a 24-hour period during the period in Ohio, for which was really encouraged to shelter in place. So I would say it's all about volume and
maybe a better question might have been, maybe a better question might have been, was that a change that was made in terms of registration with the state, or was that a change simply in practice, that they are still urgent, they're still freestanding emergency centers, but they are focusing on urgent care at the moment?
Yeah, I don't know the details, and I was curious because, as Stephanie mentioned, my background was emergency department before I had come to IT, and so I was curious to know whether or not they had arranged that through the state so that they could reopen without difficulty, right? Because my understanding historically was, if you close an emergency department at any time, you won't be able to reopen it as an emergency department. So I don't know if that was, if they're going to be bound to that, or what hoops they'll have to go through if they do intend to reopen them as CDs.
Okay, thank you.
This is Stephanie. A related question, actually. So from a provider standpoint, obviously you had your ED staff teed up to operate these freestanding emergency departments. When it shifted to urgent care, did you repurpose primary care doctors from other places? Were they seeing reduction in volumes and therefore you had staff to reassign? How did that work out from an operational standpoint?
Yeah, thanks. So initially we utilized the same contracted ED physicians to staff the urgent cares, but over time we are adjusting that to primary care physicians and nurse practitioners.
Okay.
For our emergency department physicians, with the exception of our academic medical center, our emergency departments are all contracted groups. So,
Okay.
like I said, they had to work through that. So initially, they reduced their hours, but we're seeing patients only as urgent care patients with the same, you know, emergency medicine boarded physicians that were contracted, and then one by one are replacing those with the family practice or primary care physician staff.
And you may get to this, but you have a slice of your pie here dedicated to telehealth expansion. What sort of percentage increase did you see as you were going through the thick of it, as it were, right? And folks were really avoiding coming into practices. And are you starting to see any rebound effect at this point?
No, I think we continue to increase telehealth services. I think that but where folks were hesitant over the past several years, we've had the telehealth capabilities for years. The technology has been available, but since COVID, the focus is really more to reach out to patients in that way. So the immunocompromised and Michelle was involved, right? So Seidman Cancer Center had, to my knowledge, had never used telehealth visits prior to COVID, and so they began, and I believe will continue. So I think it's been good for our outreach to patients. That our clinicians and were kind of forced down that path, and then it's just part of normal practices now to see patients in that way.
Right. Well, I think patients are getting a little bit more comfortable. I mean, nationwide anyway, coming back into the offices to see providers for things that are worthy of that. But it seems, though, through all the literature, that telehealth is really here to stay. Just it'll depend on how the reimbursements support that.
Right. So the same piece of the pie that I've been talking about, really patient access, portals, and patient engagement. It's really the same group of individuals is responsible for our ADT system, and they were doing location build, right? So we were, for every location, the hospitals were coming up with a plan to upsize to 300%. So we didn't build out to 300%. I think somewhere in the range of maybe 150%. It might have been what we had done, but we had plans and we had phases to do that. So that took a lot of effort, right? Is to work through with each facility how they intended to utilize their beds and upsize their facilities for surge. And then, as you might guess, when we didn't utilize that amount, when we didn't have a surge in Ohio, or at least Northeast Ohio, to speak of, I think probably somewhere between 90 and 100 is the highest number of COVID positive patients that we had on any given day, and spread across 12 facilities is, it was manageable.
And are those numbers steady? Sorry.
No, they came down, right? So we still do have COVID patients across the health system, but the numbers are small. And like I said, our emergency operations center just continues to operate, and I think they may make a decision to pare that down in the coming month or two. So the majority of things that my team was responsible for were clinical workflows, and I didn't mention something big. I mean, every health system or hospital system probably has their story about, you know, what they were focused on when COVID began in early March. And the UH story was, you know, we didn't always have 11 community health centers. We, in 2015, starting about 2015, we acquired 5 new hospitals, and one of which was, you know, partly was not fully independent. I mean, they were part of our health system, but they were not wholly owned. That was St. John Medical Center in west of Cleveland. But 4 other hospitals that were independent were acquired by university hospitals in or about 2015. And so we, you know, planned and ended up converting those hospitals over to our core IT systems between October of 2018 and October of 2019. So we converted all 5 hospitals and, you know, got them onto our core systems. So as you might guess, you know, I told you one of our challenges was we don't have a fully integrated electronic medical record. Imagine what would have happened had COVID hit, I don't know, 6 or 8 months or a year prior, when we had, you know, several different EMRs. And so I can't imagine what that might be like for health systems that have various EMRs across their system. But you know, that's really what our story was. You know, we had just finished that conversion of everyone onto the Allscripts and Saurian platform, Oracle for our supply chain, and we had just completed that, and we're working on optimization and focus on archiving the EMRs. And of course, like I said, I just can't imagine. I mean, that's really the glass is half full kind of perspective, is we're so fortunate to not have to do this for 4 or 5 different EMRs. You know, we had a mixture of a couple of different versions of Meditech, Cerner Saurian Saurian clinicals, and we had a Cerner Millennium, and then there was another hospital that was on the same version of Allscripts that are inpatient at the UH Core Hospitals is on. So is there anyone that represents, so I guess I'm interested in understanding, you know, what's the fully integrated perspective from an Epic or a Cerner and COVID response? There any challenges that that you had with making changes or adjustments to accommodate requests from the clinical and HICS team?
I might have something to say about that. My name is Randy Piles. I'm actually the IT system administrator for telehealth at the University of Kansas Hospital. We do have a unified Epic. I'm not on the Epic side, so I don't know a whole lot about that, but all we have is Epic. And our big battle, as far as I could tell, was getting Zoom integrated in such a quick way, which definitely was not easy. That, you know, we, at the time we had got it done, it had taken about 2 or 3 months, and we hadn't planned on doing that for at least another 2 years. But we had all of the plans in place. It wasn't an easy integration, and I don't know if we'll stick with it, but it definitely could have been much worse if we didn't have just one Epic system. That definitely would have been a lot harder, but it wasn't too terrible.
Okay, good. Any other perspectives?
Hey, it's Stephanie. I'd be curious to know, and it might be a little premature because I know this just happened with Epic, but they've partnered with Twilio to provide an integrated, more
Yeah.
user-friendly platform. Has anyone used that yet?
I would be also interested in that because we're talking about doing that also.
I mean, it is relatively new, like late April, so it's
Yeah.
probably completely available everywhere, but that seems to be their going forward solution.
I can tell you this, we are just now asking our questions, but I did see a demo of kind of the mobile version, and it seemed functional but basic.
What I read, and I don't want to derail the conversation, but what I read is that, the challenge with having it inside Epic from the provider standpoint is how much can the provider look at one time and still be effective in documenting what's happening.
Yeah.
So it'll be interesting to see how all of this, quote unquote integration actually impacts workflows for the providers.
Well, I can tell you for us from a purely traditional IT guy point of view, it should make things a lot easier, from my end, because right now we use Zoom. So everybody has to have a second app. You launch the button, you go into my chart is kind of the public facing version of Epic, or what we use anyways. They go into my chart, they launch the button, and whether they're on desktop, laptop, Android, iPhone, they have to have the Zoom app installed. It launches all that. Twilio is based on the WebRTC standard, which is basically video just through a browser. So there's no third-party app. It's much more condensed like that. So I know that part is going to be easier.
Hey, this is Kirk Ollinger. Will that app then run across your Epic web servers? Because today with Zoom, when you're launching that app, then it's going
Yeah.
out to your local device and it's using your computer overhead of the local device there that
Mhm.
you have in your hand or on the desktop. But if it's running through Epic, does that mean it's running across your Epic servers?
I would assume so. Yeah.
Okay, so that's probably the main reason for the reduced functionality then.
Yeah. Yeah, absolutely. And Twilio being, and I'm still learning about it myself, but Twilio, unlike Zoom, where Zoom just does the one thing, Twilio seems to be a whole ecosystem of communication APIs. So I see it as that's what it is right now. But it's going to get better. There's going to be more functionality. The functionality is going to take less overhead. So when I see it as that's a great start.
Mm-hmm. And I don't think anyone on. Sorry, go ahead.
Sorry, this is Zach Brott, University Hospitals. So we're leveraging one of those APIs or pieces of Twilio. Now, obviously, it's not going to be integrated with Epic because we're an all-script shop, but we're leveraging Twilio to automate text message appointments. So there's an SMS component where essentially a clinician or caregiver can generate a meeting with our CMS WebEx meeting server, and Twilio in the background will automate the text message to meeting recipients. So where they can just get the text message and it's a one-click right into the meeting to meet with their loved ones or care team or whatnot. So that's what we're leveraging Twilio for.
Yeah, and that's actually something I brought up to something like that to one of our executives that we were talking about it just as an example of things that could be done. So I know it's all scripts and not Epic, but I would be interested to see how you do that.
Yeah, so I guess it's Candace, from a documentation standpoint and integration, we've always had, we've never had integration, and we don't, going forward.
Yeah.
I think they are looking to have some integration perhaps with, patient portal, and we're utilizing Conversa, as something. It's a part of a patient engagement package. But when we started this, essentially around COVID, we said utilize the same notes that you use, if the patient was in front of you. But I think they are working to integrate that with the scheduling system, though, too. Is that right, Zach? So they're working to have full integration with our scheduling platform, the Cerner Sorian. Yeah. So that's where the integration will come in. But in terms of the clinical workflow, it's still separate. The virtual visit platform is separate from the documentation. It's unfortunate, but it is. Thanks. That's good. I mean, I appreciate everyone's jumping in here. I'm getting tired of hearing my voice. So, I did want to spend some time so that you had a good understanding of what the biggest piece of the pie was. But my team is really responsible for a lot of the clinical workflows. So the bottom, pie, right, for clinical workflows. So if we go on to the next slide, I kind of wanted to talk a little bit about that, and you can stop me at any given point. So don't know the what's most important to you, but really this is kind of listed here as a cyclical process, because almost every one of these we had to revisit and make adjustments throughout the course of the last couple of months. So from an inpatient standpoint, when we initially said, okay, what's the first thing we do is how do we screen the patients and document the screening of patients in clinical documentation so that we can appropriately mask and isolate them and locate them to the right area of the emergency department or waiting area or so forth. So while that was the first thing, we have a phase 2, right? So we're revising all of the patient screenings, and those will go live this next Monday. So, on every entry point of the hospital from a documentation standpoint, that's been pretty consistent. We might have made a couple of tweaks here and there, but that, again, we're revisiting it. So it's not as though this is linear where we do it once and we're done. We just keep doing it, right? Evaluating where orders for tests should be available has been an ongoing work effort. So when testing was limited initially, we had to ensure that there was a small subset of the health system that was able to, to evaluate based on criteria who should have testing and be able to order that. And that's still, ongoing. And we can talk a little bit about that, Michelle, if you'd like. And when you talk through, our ambulatory oncology, order sets, creating order sets, revising order sets, adding automation and clinical decision support to order sets has been something we've been doing. And significant tests around the significant, COVID-19 testing updates. So that might have changed on an every other day basis. UH was one of the first health systems in the United States to be approved for clinical trials for medications. So we're building out order sets for clinical trials, and so that was back in very early in March timeframe. The emergency department, as I said, we had kind of built out for more space in the EDs, and then in the long run, we ended up closing freestanding EDs. So just everything from the gamut of ensuring they had appropriate tent space outside of EDs, and they were technically capable of taking care of patients outside, and like I said, just everything you can imagine, and then transitioning them to a new EMR mid-April, I think that was, or early May. So I'm going to let Michelle take it from here. She really kind of covers the surgery area and ambulatory oncology, but a lot of what she says about ambulatory oncology is not necessarily unique to that area at UH. Similarly, we've experienced that in all of our physician offices. So, Michelle, you want to take it from here?
Thank you, Candace. Good morning, everyone. Things really ramped up in the beginning of March for ambulatory oncology. We were notified that our physicians who prior to the beginning of March had no engagement or interest in telehealth or virtual visits really felt it was necessary because of just how ill and compromised our oncology patients are. So in 10 days' time, we got 46 providers trained in DoxyMD, and they started using virtual and telephone visits. And most of our clinic visits, except for the really extremely sick, which they encouraged instead to go to the emergency room, became virtual and telephone visits. And then over the next 2 weeks, as physicians returned from conferences, we added a few extenders on, we trained more. And I can honestly tell you that the bulk of our visits are still to this day in ambulatory oncology clinics, virtual and telehealth. We also started looking into using Navimize, which is an API that alerts patients about their visits. So for our patients that do need to come in, it sends them a text message that their scheduled appointment time is on target, or please show up 15 minutes late. And we have received really good responses from that for our patients that do indeed have to come in. Along with virtual and telephone visits, we needed to create a consent for that. And we also needed to update our documentation for billing purposes so that our billers and coders could appropriately bill. At the same time, we had plans to roll out EPCS, which is electronic prescriptions for controlled substances. Plans to do that the end of March and the beginning of April, but we needed to expedite that. So we started that on the 18th of March as well. So our providers had a lot of change on the 18th of March between EPCS and virtual and telephone visits. We also, for the patients that did need to come in, it was identified that we needed to screen them. These were very sick patients, and they were immunocompromised. So we opened what we called our Sideman respiratory clinic. So all patients who did need to come in and be seen in the office were pre-screened with a rapid test. And that is still ongoing today. And we also just implemented 2 days ago, on the 23rd, We have an order set that we use for the purposes of communication and scheduling from our clinics to our infusion centers. And we implemented a section where it is indeed marked off by the provider who is ordering the patient to come into the infusion center that they have been scheduled or have been, with the date, recently COVID testing, so that they will know, the nurses will know to look up ahead of time, make sure that the appropriate accommodations are made if our provider has decided that the patient needs to continue to receive chemotherapy even if they are COVID positive, or if they are COVID negative. Of course, that also helps. We utilize Navamize a lot for that as well, to communicate to our patients. Give us another 30 minutes because we're looking into things. A test result might be, not quite back yet, but we're a little concerned that the person is indeed positive. So we have implemented those 3 things, and we're getting very good patient satisfaction results from those. Does anyone have any questions about what we've done from an oncology perspective? Any comments of what you all had to do? Okay, then I'm going to move on to surgery, and I'm sure it's no different than all the rest of you because we all went to essential surgeries, and you had to have your providers, your surgeons involved in that. Because we had to do it so quickly, I believe our governor instituted it on St. Patrick's Day. We came up with a paper form that actually had to have 2 signatures on it, that the surgeon was indeed saying this was an essential surgery, and then the chairman of the department also had to sign it. And that was reviewed by the pre-op nurse. And if it was not signed and not in the chart, we did not go forward. So as you can imagine, as everyone else, our volumes decreased greatly in surgery, but then even the volume we did have, we were seeing delays because we did not have this essential surgery consent available or signed by all the necessary parties. In April, we did institute, again, using DoxyMD for our pre-admission testing so that patients did not have to come in because all of ours are associated with our hospitals. They may not be, right in the middle, but you still have to go to the same front door, park in the same parking area. So we instituted telehealth for that, except for the patients that absolutely needed to come in for lab draws or chest x-rays or EKGs. We also started, things started to open up a little bit here in Ohio in May. And we had to add, as we started to allow more patients back in for surgery, we were allowed to bring in ambulatory surgeries. Patients who needed overnight stays, we did not bring in the beginning of May. But we really felt that it was necessary to add a delay reason of the COVID result. The governor did say that the patient needed to have a COVID test within 72 hours of the scheduled surgery. And of course, we had to have the result back. So we built into our system a delay reason for the COVID result not being back. And we also, our Cerner Saurian ADT system, we also used a combination of when we canceled our patients in March and April, it was flagged in a way so that Saurian would notice that that patient was canceled because of COVID. We had the COVID reason in there so that when we were allowed to open back up, it was fairly easy to see what patients needed to be contacted so that we could get them back in. And looking through my notes here. And then the last few things that we have done is we have implemented a surgery reservation form that is an interactive PDF. And we actually had that out there since August of 2019, but we did not have a lot of engagement. And when we started bringing our patients who had been canceled because of COVID back in, the engagement grew exponentially. I think we're up to like 88% of the use of that. So they're no longer faxing in a surgical reservation form. We're actually using technology to help us get all these patients back in. And it made it so much easier to reschedule these patients because we had all that information on that surgical reservation form. It was much easier to get it reinstituted, to get the information out for pre-authorization so that we wouldn't receive denials. We've also had to update our consent forms as well as our documentation forms. The day of surgery, update H&P needed to say that the surgeon was indeed had reviewed the COVID result, and if it was negative or positive, he had to note that. We also have a functionality where when you need a physician to sign an order or to sign a note, it's called Signature Manager. That is the first thing that pops up when a physician logs in if they have something that they need to sign. And we created, not a very nice name, but I'm going to call it a dummy order, so that in Signature Manager, when that surgeon logged on, he or she would see, yes, indeed, the patient had a COVID test, and I'm aware that it's positive, so that we had, documentation in the electronic medical record that the surgeon was aware that his patient was COVID positive, had alerted the OR so that the appropriate PPE and precautions can be made, and it was documented in the legal medical record. And then the last thing that we have implemented, I talked about that surgical reservation form. We have rolled it out. It's been live a week now to our procedural areas, our cath lab, our EP lab, and endo labs, so that they can use that form as well. So COVID forced us to come up with a much more streamlined process because all of those forms come into the schedulers, and when the patient gets scheduled, an email is sent back and confirmed. So we had some efficiencies that we built in thanks to COVID. Interested to hear if any of you had the same type of things you needed to do and what technology you instituted, or if you had something a little different. Stephanie, this is the second week in a row that they're quiet.
It is a bit quiet, I know. We warn you all out with all of this data and information. Well, this is a great, journey that you share with us. I think it's super interesting. Does anyone have any comments or responses to Michelle's questions? Kirk and Alan, I know you're always good for questions.
Oh, thank you. I'm just amazed at the incredible amount of work that's gone into this. You must have a very dedicated team.
Well, we sure do. I mean, as we look back, obviously, the team itself has been displaced from their normal working location to their homes, and like all of you, right, homeschooling children and kind of worrying about their own, family's needs at the same time, we were meeting. My team, right, was meeting 7 days a week around how do we ensure that the clinicians are not waiting on us, and things have normalized a bit for us, but like I said, I think it's important to know that there are still leaders in our health system that are living this pandemic day and night, because our concern really caring for our patients, caring for our employees, right? So that's always been the two driving forces is that we ensure that our patients are safe and well, and our caregivers are safe and well, and then obviously we've got to be able to do well to do good, right? I mean, that's the key here, right? I mean, we still have to financially be successful so that we could provide good services to the community.
Yep, agreed.
Have you guys found that the productivity, and this is just, I'm asking because we've heard a similar theme throughout most of these calls with our health systems, but are you guys finding that the productivity has not suffered having people work from home remotely?
UH, I would say, yeah. So some of the requests on the clinical side, let me just say that, you know, obviously IT wasn't the only departments that went remote, but some of the requests, as I looked through them in preparation for today, was around productivity reports. So I think some of the leaders in the health system were concerned that their team members would remain productive, and so that was an IT ask, right? So please make sure that we understand how productive our teams are. I, just from my perspective, my team's still been incredibly productive. I do think that those that have school-age children have been really challenged when daycares closed. You know, daycares have closed, and I'm flexible, but I do have high expectations. So, I think we have to figure out ways to ensure and have some difficult conversations to say, all right, so this continues, and then how do we ensure that, you know, your hours can flex so that you can continue to be as productive as you always had been. We have tools, and I've, you know, hesitated to, you know, really get after folks. But like I said, my team's been incredibly productive, and my leaders, you know, my managers that are on the phone and those that aren't here representing themselves have been amazing.
That's great. Are you starting to bring folks back on site? Are you doing it as a percentage and or work sharing or hotel room style or hotel desks? What is there a strategy for bringing people back into the office?
Not for IT right now. We don't have official plans. By hospital, the traditionally hospital-based team members, I think yes, but not the corporate system.
Yeah.
Hey, this
But
is Kirk. I know
otherwise,
we're up.
Yeah.
Well, I'm sorry.
Please go ahead.
Yeah. No, I know we're up against the clock, but something that you had mentioned triggered a question. You said, so there were a lot of requests for reports from IT to make sure people were you know, remaining productive, or so that they can measure that. Does that mean that those KPIs were already in place for measuring those, or how is it that you're determining that your IT people are actually remaining productive?
Well, and we utilize an application called Workfront. So for me, productivity would probably be measured using that tool, right? So they log their hours against particular enhancements or projects. And so we do have baselines. For the ones that I saw in the one of the categories that I don't am not most familiar with, I think it has to do with understanding how many appointments they're scheduling and so forth. So they must not have had a baseline before by individual, but rather by department. And I think they just needed to ensure, you know, the team members were scheduling and rescheduling. Yeah.
Okay, thanks.
Great. Well, it's the 12 o'clock end of the session, I'm afraid. I hate that we don't have more time to dive into additional conversations. This was a great presentation. Thank you guys so much for sharing the UH journey. For those of you who are interested, we can make these slides available to you for later reference. And as I mentioned, this will be posted to the education website. That'll go out in a link to you later today. So this is our final weekly call, as I mentioned. So it's been a fun 14-week run. We've seen, lots of ups and downs in terms of the pandemic over the course of this journey. But what we're looking forward to doing is really reconvening once a month for a while to not only talk about our COVID status, but really best practices more broadly. I think that healthcare is obviously changing in some pretty major ways. And as we look forward to what that looks like in a post-COVID world, we're all going to have more innovations, more great ideas to share. And this has really been a great opportunity for all of our friends across the country at different health systems of different sizes and different shapes to come together and share their ideas. So we hope you'll continue to come. Your invitation that you when you register for this session will carry over, so you'll get a reminder about those monthly calls. We'll do our ramp up ahead of time, so as we start teeing up speakers for those, we'll make sure you are given plenty of notice, and hope you'll continue to reach out to us if you need anything or have any additional ideas to share. For the folks at UH, we are very much looking forward to working with you on our in-person healthcare education summit. It's supposed to be this April. That was canceled for obvious reasons. We were planning to move it to the fall, which looks like that's going to be bumped as well, but we will be there. So we're looking to do something in the spring of 2021 with you. And so we'll be on site, and there will be no shortage of new topics to cover by then. So we're looking forward to planning that out and working with you guys and coming on site and seeing everyone in person. It's been a weird time, so it's going to be nice to get some FaceTime versus all this virtual stuff. Michelle and Candace,
thank you.
And this was lovely. We really appreciate your time, appreciate your insights, and we'll look forward to talking with you all soon.
Thank you. Take care.
Everyone.
Thank you, everybody.
Bye.
Bye.
Bye-bye.
Okay, thank you.